Good morning, distinguished guests, and welcome to day 2 of the ACS. I am Dr. LOLO SHUNOM Ayuba, a resident cardiology medical officer in CardioCare Multispecialty Hospital. And this morning I'll be presenting our first case report. This is a 78-year-old male being managed for hypertensive heart disease with heart failure, chronic atrial fibrillation, a previous stroke, and benign prostatic hyperplasia. So these guys presented with generalized body weakness, worsening dyspnea, and cough of about a week's duration. The generalized body weakness was said to have worsened 2 days prior to presentation. He was unable to ambulate without support and said to have fallen on 2 occasions. So the cough was said to be productive of whitish sputum. Dyspnea was initially moderate, or was initially on moderate exertion, but progressed to even dyspnea on mild exertion. And he had, however, had no orthopnea or paroxysmal nocturnal dyspnea. So on examination, he was lethargic, drowsy, with bilateral pitting pillar edema. Pulse was barely palpable. The heart rate was about 35 beats per minute. Blood pressure was unrecordable at that point, and the heart sounds were S1, S2 with ectopics, and power was about 4/5 globally. So an assessment of cardiogenic shock secondary to biventricular heart failure, New York Heart Association class 3, precipitated by atrial fibrillation and urinary tract infection in background hypertensive heart disease, a previous stroke, and BPH. So this was the ECG done on presentation. So from this ECG, we could see irregular RR intervals, no identifiable P waves, a broad QRS. The heart rate was about 48 beats per minute, a broad QRS complex, dominant R wave in V1 with an RSR pattern, and deeply slowed S wave in V6. So the rhythm was an atrial fibrillation with a complete right bundle branch block with broad QRS complexes. So an echo was done as well. The echo showed moderate global hypokinesis of the left ventricle, moderate impaired left ventricular systolic function with the EF 35 to 40, restrictive left ventricular filling pattern consistent with elevated left atrial pressure. The TAPC was 1.3 cm, E over E prime was 20.9. The global longitudinal strain pattern on echo suggested an infiltrative cardiac disease with a bullseye appearance. So we could see the areas of hypokinesis on the GLS. Sorry, of akinesis and hypokinesis as well. So Holter showed atrial fibrillation with a ventricular rhythm. So other investigations included the lipid profile, which was unremarkable. Uric acid was also within normal range. The HbA1c was also within normal range. Urinalysis showed 3 pluses of glucose, plus of protein, 2 pluses of leukocytes. So electrolytes, sodium bicarbonate, urea and creatinine were as well deranged. Full blood count, okay?
Please, let's go back. I'm not sure they understood what you are saying. Go back again. Go back again. Okay, so what we can see from this ECG is that it's a very slow rhythm. We are going to do ECG today, and we'll be able to, Dr. Lolo, can you show them? Go there, the operator does not work. Show them. You can see all these things that look like mountains, Abby? Can we see them? So that's, imagine those are big heartbeats, right? 1 heartbeat, second, third. Now, if the 2 of them were here, 1 box, it will be 100, the heart rate will be about 300. If it's 2 boxes, the heart rate will be about 150. 3 boxes, 75, 4 boxes, 60. Okay, and so this is a very slow heart rate. Also, it's a very wide QRS segment. We're going to talk about that later. We also can see that it's irregular. Can you see that it's irregular on this place? From 1 to the second one to the third one, the distance is not the same, right? Can we all see that? Beautiful. So that's what we call atrial fibrillation. When the QRS complexes are not regular and there is no P wave, we say that's an atrial fibrillation. Go to the next slide. On this echo, what I want you to take note of is this thing that looks like a donut. Can we see this thing that looks like a donut with colors? So this is a what we call a speckle tracking part of echo. Very, very important in this particular case. Because what it shows, the more red the area, the more contractile that area of the heart is. Do we understand that? And the more pale it is, the less contraction it is. So sometimes this speckle tracking, we use it because the center, does it not look like a bullseye, like you want to throw a dart at it? It means that only the apex of the heart is contracting well. The rest of the heart is not contracting well. That is a very characteristic pattern in an infiltrative cardiac disease. Infiltrative cardiac disease, like amyloidosis, something where an external thing is infiltrating the myocardium of the heart. When it enters the heart, more often than not, it spares the apex, and this is called a bullseye appearance. So when we look at everything, we can see this bullseye appearance, we can see a slow heart rate. We'll be thinking, and this pattern, we'll be thinking more of a cardiac amyloidosis. And those people are very prone to having heart blocks, and this patient already has right bundle branch block now, Abi, and now is having bradycardia, has had atrial fibrillation, is in heart failure. Okay, so that is why we consider intracardiac amyloidosis in that case.
So he was admitted into the ICU, and antihypertensive medications were withheld because of the unrecordable low blood pressure. He was commenced on IV fluids, IV dopamine at 5 micrograms per kilogram per minute, which was titrated as required. IV noradrenaline at 0.2 micrograms per kilogram per minute as well. So the guest and the relatives were counseled on the need for a cardiac device therapy. He was continued on his tabs with rivaroxaban and glyphosine as well. So urine MCS showed moderate growth of Staphylococcus aureus sensitive to piperacillin, tazobactam, gentamicin, ofloxacin, tetracycline, clindamycin, and cotrimoxazole. Blood pressure and pulse improved on inotropes. However, the heart rate kept fluctuating, getting as low as 24 beats per minute at times. And the guest was immediately moved to the cath lab and planned for an emergency temporary pacing and a cardiac resynchronization therapy pacemaker as soon as guest was ready. So emergency transvenous temporary pacing was done because of the occasional fluctuations in the pulse, and a 6 French femoral sheath was placed in the right femoral vein. A temporary pacing wire was inserted through the right ventricle under fluoroscopy in the cath lab. Pacing was set as VV160 with good effect to maintain a heart rate of 60 beats per minute, pending full device implantation.
All right, so just go back. Let me just show you something here. Now, this is what we call temporary pacing. When patient is having, this patient immediately was getting heart rates as low as 20. So before you're ready for anything, you need to save that person, right? So I will show you something you can do in your centers during the ACLS, pending what you can do. But if you have access to these devices, this is a temporary pacemaker. We typically have one in the cath lab. It saves lives literally. It's my best friend. So what we'll do is, as you can see, we just get the femoral vein. I'm sure some of you are used to getting samples on the femoral vein, right? Same thing, no difference. The exact same thing. You can do it if you can get a sample of femoral vein. When you get that femoral vein, as you're trying to take the blood, Abby, we remove the syringe. The blood is still coming out. We pass a wire through it into the vein. We remove that syringe, then we take a sheet over it, like a cannula, over that wire, and it stays inside. Beautiful. Then we take the temporary pacing wire. I'll ask them to bring some of them over from the cath lab so that I can pass around so you can see it. And we pass through it, looking at it under this, in the cath lab, under fluoroscopy to see how it is going. As soon as it enters the right ventricle, that is all. We connect to this one, and then we manipulate it, and it will now start beating. So this is called VVI 60. Don't worry, that's too high. But we'll start pacing. We'll start pacing the heart. So we got the heart rate back to 60, and then that was around 2 a.m. So I put it around 2 a.m., went to sleep. Then the next morning, we now put a CRTD. So the CRTD is a type of pacemaker. Why did we put a CRTD here, Dr. Lolo? Why did we choose the CRTD and not a pacemaker here? Remember I told you I'll percuss you.
Okay, we chose a CRTP in this patient because the patient's heart...
No, D we did, okay, not P.
Sorry. We chose a CRTD in this patient instead of just the typical instead of just the pacemaker, because this patient is also at risk of cardiac arrhythmias. So the presence of the defibrillator will help to arrest those arrhythmias in case they occur. Else, if you had put just a CRTP, the patient's heart rate will just be resynchronized and it will be paced. But in case of any arrhythmia, he will not have, the device will not be able to defibrillate for the patient. So
why should we do a CRT and not a pacemaker, just a normal pacemaker?
Okay.
Let's see whether you are paying.
Okay.
Dr. Amin, I hope you are getting ready, and Dr. Fatima, start doing press up.
Okay. For this patient is already at a point of advanced heart failure and had been on medications for a long period of time. However, the heart rhythm was still not synchronized. And instead of just pacing for someone who would just have symptomatic bradycardia, this person's heart will require resynchronization to aid the ejection fraction because of the ongoing advanced heart failure that had already been profound in this patient. So this patient will require a CRTD.
Let's clap for him now. The guy is on point. So when he becomes a cardiologist, we will know. And so essentially, when people have heart failure and they have a reason for pacemaker, putting an ordinary pacemaker will worsen the situation. The patient may seem to get better, but really you're going to worsen the situation. So we do not advise that. So sometimes they just say somebody needs a pacemaker, his heart rate is slow, and they just rush somewhere, somebody just puts a pacemaker and say, well, I put pacemaker. No, it will worsen the case. Because remember that the pacemaker will cause some desynchrony. It's going only into the right ventricle. And it's going to be just beating that right ventricle and leaving the left ventricle alone. So that will cause the right ventricle to contract, left ventricle to contract later, and widen everything and to worsen the heart failure. So for you to pace that kind of person, you need to put something in the right and in the left, so that both of them will pump at the same time and improve the cardiac function. Not that one is pumping, then wait for the other one to pump. That will worsen the patient's overall cardiac function. So patients that have a need for pacing and have heart failure, typically we do not just put a pacemaker, we do a cardiac resynchronization therapy pacemaker. Now, if we think they are also at the risk of sudden death, like in these patients from arrhythmias, we now also include a defibrillator. So it's a bigger device, same procedure, but now this is now something that can shock. Remember we were showing shock yesterday, Abi? But now this is inside. It's like having an AED inside somebody's heart, constantly monitoring the rhythm and then delivering shocks when necessary. Okay, so that is what a CRTD is.
So the CRTD was implanted and was implanted successfully. The procedure was well tolerated, and post-procedure vitals showed a pulse rate of 70 beats per minute, blood pressure 129/78, respiratory rate 18 cycles per minute, SpO2 98% on room air. So he was placed on IV antibiotics post-procedure, while some of his routine medications were restarted, like the tab spironolactone and IV torsemide as well. And the blood pressure had improved, so inotropic support was discontinued. So this is a chest x-ray showing the implanted CRTD over there in the pocket under the skin and the leads going into the ventricle. So post-CRTD implantation shows a paced rhythm with a pacemaker spikes. So typically, wound dressing is done 5 days post-op with and the patient has a broad arm sling to ensure minimal movement of the hand so that you don't dislodge the leads of the device. And patient, after wound dressing was done 5 days post-op, patient was discharged on oral antibiotics and his routine medications as well. So with the device, he's still supposed to continue with his medications. So he was counseled on device care, and he was to be seen in clinic in 5 days to be reviewed and to also have another session of wound dressing. So guest presented for follow-up 5 days after discharge, had no new complaints and was doing well. Pulse rate was still good, blood pressure was 90/60, and heart sounds were S1, S2. So the ectopics were. So it was planned for continued follow-up. So it was planned for continued follow-up to continue on, of course, counsel medications, even with the device on his heart failure medications, even with the device, each patient is still to continue with heart failure medications. All right.